record. Okay, isn't that more section, I think, Cole?
Yeah. Recording started. Okay. Recording started, everyone.
Yeah, very good. Okay.
Well, thank God someone has a good memory.
No, I don't.
Oh, Rita's there. You select Rita, and that's good.
Is that any better for me now?
Oh, a little bit better, yeah.
Oh, yeah. There you go. There's only one of you now.
I think Rita's there as well. She doesn't have a mic on.
Yeah. She's muted.
Yeah. Oh, good morning, she says.
Yeah.
It's typed it in.
Yeah.
All right. Do you want to start off, Cole?
Oh, you better, Chris, because I'm just going to duck out for a sec and see if Elizabeth's on the other line, and I'll try and bring her over.
All right, okay.
So I'll be hopefully back within 10.
All right, mate, I'll just kick it off. Okay. Can you guys see that? Is that up there, Cole, the thing I've shared?
Oh, hang on.
Or
Yeah,
not?
see the hemorrhage and shock.
Oh, okay. All right. Well, that's good. Okay. All right. We'll get started. I guess this session, we're going to talk about hemorrhage and shock. Generally speaking, a lot of that comes into what we do as paramedics. The hemorrhage is fairly straightforward, but we need to know a little bit of anat and phys behind it, not a great deal. And then shock is something that we're going to talk about, you're going to hear about. And there's different types of shock, and it'll all fall us into perspective when we discuss it, because it's a subject that people can get easily confused by. And this sets you up well for your workshop one, because a lot of this will be spoken about, and these are the things you're going to find in some of the exams moving forward. And it's important to understand the different types of shock and how we go about treating it, the background in relation to certain medications and drugs we use, as well as fluids and the types of fluids that we use in dealing with shock. So not every form of shock requires fluids, and not every form of shock requires drugs or medication. So it can be a little bit confusing. So we'll just run through the hemorrhage to start with, and we'll just speak briefly about that, and then we'll go into the types of shock, the signs and symptoms of shock, and how we treat it in the field. So the first bit we'll speak about is just the basic components of blood, which you guys have already done in your AMP module, so you should have a bit of an understanding about that. Hemostasis and external control of hemorrhage. All right, so as we know, I need to make that bigger somehow so I can't see the bloody thing. The components of blood, as we know, is made up of plasma, white blood cells, red blood cells, and bits and pieces. So the average adult male has a blood volume of around 7% of total body weight. As we know, most of our body's made up of water, around 60% in water. The average female has a little bit less, 6.5 of total body weight. The volume increases during pregnancy. As we know, the fetus requires its own blood supply. So obviously that volume will increase in the female during pregnancy. Normal adult blood volume's 4.5 to 5 litres and remains fairly constant in a healthy body. It can be said that's probably a little bit higher, appropriate to obviously your person's weight and size. So it's a little bit over that. It's probably close to 8 litres. All right, and the blood consists of your plasma, as I said, red blood cells, white blood cells, and platelets. So we'll have a look at plasma. It makes up 55% of the blood volume. Approximately 92% of that is made up of water, circulates salts, minerals, sugars, fats, proteins throughout the body. The blood cells, platelets, and other substances are suspended in the plasma itself. Now, red blood cells, erythrocytes play an important role. 99% of our oxygen attaches to the hemoglobin in blood cell count. And that's why having correct oxygenation within our body is so important to our hemoglobin, our red blood cells. Remaining 1% is carried in the plasma. Most abundant cells in the body. So there's more red blood cells than anything else. Provide oxygen to the tissues and it removes carbon dioxide. So it works around the body, through the lungs, back through the heart, through the lungs, to remove and blow off that carbon dioxide. And as we know, carbon dioxide is one of our waste products. Platelets and white blood cells. Platelets aid in the hemorrhage control, so we need that to control our hemorrhage. And that's why it's important that when people do lose blood, they require some replacement of platelets and red blood cells. White blood cells help to fight infection and make up part of the immune system. And that's why our immune system is so important to us with particular types of cancers and things. And we need that immune system to help us fight that infection. So it's important we have a healthy immune system. So hemorrhage, we'll just have a quick look at some of the types of bleeding. So we've got external bleeding, internal bleeding, from capillaries, from our venous system, and arterial bleeds, which obviously can be quite life-threatening if we have an arterial bleed, and that's one that most certainly needs to be controlled fairly quickly. And there's just a couple of examples of that. We can see that the capillary bleed's only a very small, weepy type bleeding scenario. The venous bleed, there's a bit more blood about, but it's easily manageable. But the big one is the arterial bleed. As we know, that the arteries are under pressure, so the blood that's coming out is under pressure, and that's why we tend to lose it fairly quickly. Well, something bad's happened there. What's happened there? I'm back. That'll happen there. Causes of bleeding: lacerations, tearings, and amputations. The big ones, the laceration is not too bad. It's the tearing type ones, like in shark attacks and things like that. They're the ones that you do a lot of damage and you lose a lot of blood. Amputations, depending on the nature of the amputation, generally if an amputation's a clean amputation, they don't tend to bleed that much, strangely enough. But if it's a tearing sort of mechanism, like with a shark attack, you can have that significant blood loss. We've already spoke about the average. So when you look at how much we're pumping around the body, so let's say it was 5 litres, 70 mils by your 70 beats a minute gives you roughly your 5 litres. And then as you can see there, if your heart rate increases and you're losing blood, as an example there, 20 mils by 120 beats a minute, you've come down to 24 or 2.4 litres, which is 50% of that blood volume. So you can see how things sort of change. So if you're losing blood, part of the signs and symptoms are that your heart rate's going to increase, and it's obviously going to pump that lower amount out. So you're not going to be left with a real lot. And then again, it comes down even further again. All right, hemostasis. Can anyone tell me about hemostasis? You would have covered that. What's important about hemostasis? Just throw it up in the chat or whatever you want to do. No answer. So none of you guys know anything about hemostasis.
So hemostasis is how active, well, pretty much controls how active bleeding occurs, and it also forms part of the clotting process, like thrombosis and thrombolizing clots.
Correct. Yep. So it keeps us in that very tight environment that our body relies on. So you're 100% right. So there's different ways that it tries to control that level itself. So homeostasis is very, very important to us. So there's lots of things to recover. So we just need that little bit of background knowledge on that as to what homeostasis is. So it just keeps our internal workings and things within a small confined variance. So there's not a great deal of variation. Once you start slipping out of that, we tend to have a few problems. So injury to the blood vessel, which is vasoconstriction. So we know that vaso means veins or the vascular system, and constriction just means it's getting smaller. So the platelets activate and become sticky, and they come in contact with damaged vessels. They'll stick to the fibres, and for a platelet plug. So that plugging factor is starting to work, slow that bleeding down through vasoconstriction. Fibrin is laid down on the platelet plug to form a mesh. So again, it's trying to entrap that blood that we're actually losing. So it's trying to protect that vessel. And this traps the red blood cells to form the clot. So if you've got a good clotting factor, that's good. So generally it starts to work on its own. And this is why when I say a clean amputation, so if we think of a blood vessel and it's cut down cleanly, as in a clean type cut, you can see when the hemostasis starts to take effect and does those sorts of things, vasoconstricts, builds up that platelet plug, lays that fibrin down, then it's trapping all the blood. So it can do it because it's a nice clean cut. So it's just forming a plug itself. So it's just like getting a cork and pushing into something just back into the cork bottle to just try to plug it up. So that's how that works. But when a blood vessel is actually torn, it makes it a little bit harder. So that tearing effect, so you've got part of that blood vessel that's all jagged and horrible. So that hemostasis thing takes a bit longer. It may not be as effective. As the clot shrinks, it pulls together the side of the blood vessel wall and helps stop the bleeding and commences a healing process. All right. So any questions on that so far? Because that's important to understand when we're dealing with different types of hemorrhage, external hemorrhage. Any questions on that? No? All right, we'll keep going. So the management of the external hemorrhage is obviously direct pressure. So the sooner you get some direct pressure on it, the sooner that hemostatic effect starts occurring. We slow down the blood flow. Elevation, we need to get blood back to the vital organs. So we need to essentially raise that part and to attempt to slow that blood flow back down. Pattern bandage, again with a direct pressure, that may well be enough to stop the hemorrhage itself. But there's an example there. And rest and reassurance. Well, reassurance is part of our job, part of our patient management. So we just keep those things in mind. So the management of its external hemorrhage is fairly simple. All right. Posture, of course. It depends on the scenario. It depends on how much blood that person's losing. Obviously, their level of consciousness, things like that. But all things being equal, if they're GCS 15, they're not losing that much blood, they'll find their own comfortable position to be in, and that's all good. If they're losing too much blood and the level of consciousness is starting to drop off, we need to think about posturing them a bit differently, which may mean that we need to put them in a supine position and perhaps elevate the legs to try to get some of that blood flow back to your major organs. So we just got to think about those things. And when you start doing your patient management scenarios and we start looking at a patient ourselves, that's what you need to start thinking about. So when we talk about posturing a patient, have a look at the patient, make sure you understand what the scenario is actually saying, and then work out what the best posture is going to be for that patient and provide an explanation as to why you're posturing that person in that position. So that's quite important. So it doesn't matter whether we're just talking about management of external hemorrhage, we're talking generally about how we posture our patients. So you need to elaborate on why you're posturing that patient in that certain position. So if they're conscious, they're alert, GC's 15, it might be appropriate just have them sitting up. Most of our patients will find their own comfort position, and that's okay. But if we need to treat a person because they're unwell or the condition's deteriorating, we need to effectively posture them for the benefit of them. So when we talk about posture, one thing we don't like seeing in your modules or exams, when it comes to posture, you don't put, wherever the patient's comfortable. We're not asking that. We're providing a scenario where there's something wrong with that person and we need to posture them correctly. You know, all things being equal, a patient with a GCH 15, it's not feeling too bad, yeah, wherever they're comfortable. But we don't put that in our answers. You got a question?
Yeah, sorry, I keep getting a notification popping up saying that someone's trying to join. I don't know whether you're seeing that as well.
Oh, yeah. Elias, I think. Thanks, mate. I just didn't see. Yep. Okay. What else we got in that? Is everyone happy with that? So what I'm trying to do is introduce some of the stuff that you're going to see through your modules and scenarios and when you go to your workshop. So posturing is one thing we need to consider. You know about rice, constrictive bandage or a tourniquet. We'll talk about a tourniquet in a moment. Oh, here we go. We're talking about it now. What is the purpose of a constrictive bandage? To constrict arterial blood flow distal to the tourniquet. What to use constrictive bandage? Nothing less than 5 centimetres wide. We don't want to put anything too narrow when we're constricting a blood vessel. Of course, we can cause further damage. We don't want tissue necrosis or things like that to start eventuating because we've put this constrictive bandage on that's going to cause that to happen. Indications for using constrictive bandage: uncontrolled by basic hemorrhage control. Our basic hemorrhage control is direct pressure, essentially an elevation, or unable to reach the affected area. Now, if we're going to use any sort of constrictive bandage or tourniquet, we only apply that over a single bone. So, in other words, even if they've got a severe laceration down in the lower calf or tib area, somewhere like that, we still apply that constrictive bandage or tourniquet up over the femur bone or top of the thigh. So wherever it is, it's only ever over a single bone. Multi-casualty situations. So if you went to a major incident, let's say, and there's multiple patients with these sort of injuries, we don't normally stop and treat. The aim of that sort of scenario is to get a good overview of what's wrong with the casualties and put them into certain categories, and that's something we'll talk about in another time. But essentially, if someone's going to bleed to death in front of you, that's probably not a good thing. So a lot of this comes from the military, where the soldiers and that will carry these tourniquets, and in the field they just grab the tourniquet, put it on, and keep going. And that's the sort of thing that we need to think about in a multi-casualty situation. If we come across someone that's actually bleeding, throw the tourniquet on and move on to the next one. That example there, we can see the effect of a wrong tourniquet applied for more than 9 hours, and see how that limb there has become necrotic, and all the cells and all that has sort of died off to leave it like that. And that's from using a constrictive bandage that's too tight and being left on for too long. When we put these tourniquets on, we normally mark them with a time, and you check around every 20 minutes and just perhaps loosen it off a fraction. If the blood's still there, just retighten it, but it's certainly shouldn't be left on for too long.
I have one of those tourniquets here at home if you want me to go grab it to show.
Yeah, if you got one, yep.
I'll go grab it, I'll be back.
Right, okie dokie. Okay, we'll wait till he comes back. Any questions so far? All happy with hemorrhage? Yeah. That's good. If you want to put anything up in the chat, you can do that. This is the easy part, I guess. We'll just move on from this shortly. Here we go. Good on you, Jacob. Let's have a look. That's it? Yep, excellent. Excellent. So can you just briefly show the guys how it goes on? You're on mute, I think.
Yeah, with these particular ones, it's got a loop, a little tightening arm. Just goes over the limb. With the strap, it's Velcroed. Just as tight as you can get it, and then you just start tightening the wheel until it's too tight that you can't get it. And then it just clicks back into where that little white tab is.
That's it. Now, Jacob's just put that on himself, and he's put it on in a couple of seconds. So they're a pretty good piece of kit. As I said, they're developed by the military, and they've been using them for years and years and years. And as you can see, that's wide enough. In the event you didn't have a tourniquet like that, you would have to improvise. So you can use anything to improvise, some clothing, a belt, or whatever the case may be, providing it's wide enough. All right. Internal hemorrhage versus external hemorrhage. Difference being internal, we can't see it. We need to be looking for signs. That forms part of our patient assessment, both our primary and secondary, which is something, again, we'd like to discuss later. We'll probably use that for another one of these sessions. So we've got internal hemorrhage and external. Okay, well, that covers that. That's pretty much covered that. All right, any questions so far? Because when I move on to shock, this is stuff you really need to get your head around. Is there any questions so far on what we've just covered? No? All good? Excellent. All right. All right, we're going to talk about shock. And first thing we need to do is define shock. So we're not talking, when we talk about shock, some people think, oh, it's a psychological thing. They've seen something terrible and they go into shock. Well, they're not actually going into shock. That's a totally different thing. That's more of an emotional, psychological thing. And it's just a term that they've used. But when we're talking about shock, we're talking about the physiology and what it's doing to the body and why it happens. And when we break it all down, in particularly when you do your modules or exams, a lot of the times the question will come up, define shock and what are the 4 types of shock. And this is the thing that the important thing that you really need to understand in answering those questions, because people get a little bit confused and it shouldn't really be that confusing, but it is. So hopefully this will set you up well for when you go back for your workshop. All right, so it's pretty easy. Defining shock: inadequate circulating blood volume resulting in inadequate tissue perfusion. What's tissue perfusion? Come on, guys.
Maybe it's the tissue that's broken, is it?
No. So
Where
think
you
about
start
firstly we'll go back. What's the term? What does perfusion mean?
Is it where your tissue starts becoming necrotic? or like damaged in a way?
So
Isn't
what
it
does?
inadequate oxygen that's being sent to the organs and tissues?
Yeah, who said that? Alicia.
So instead of blood taking oxygen to the tissues and organs, it kind of keeps it into the circulatory system instead, and they go into circulatory shock.
Yeah, kind of. You hit the nail on the head to start with. Our cells and tissues require oxygen, blood, all that sort of stuff. So we're trying to perfuse our tissues. Okay, that's exactly right. So that's getting down on a lower cellular level, down to that sort of level. We need to make sure that our tissues and major organs are being perfused. So perfusions are key. So if we don't have those, that's good circulating blood volume and the production of oxygen and all those things to ensure that, it doesn't happen. So the patient is becoming what we term poorly perfused. As a paramedic, one of the things that I learned very early in the piece is that perfusion is a key to treating your patient. Look at your patient. If they're poorly perfused, and you can see that they're poorly perfused. Once we start seeing the signs and symptoms, we know that a patient's perfusion is actually changing. So we used to say perfusion determines treatment. So if a person's well perfused, in other words, they're not sweating, they've got a GCS of 15, their heart rate's normal, they've got a good blood pressure, they're perfusing well, their tissues are getting the oxygen and blood and all the nutrients that's required to maintain that normal perfusion. We're normally perfused, we're perfusing quite well. But when things start going wrong, that perfusion quickly starts to change. And that changes with our signs and symptoms. And that's why I say important to know what our patient's looking like and why things are changing, to have that understanding. So defining shock is a simple definition: inadequate circulating blood volume resulting in inadequate tissue perfusion.
Is that sort of where they become pale and clammy?
Yeah, correct.
Perfusion?
Correct, because then we start talking about that positive feedback and negative feedback and vasoconstriction and vasodilation. That's what we need to start understanding. That yes, paleness, sweatiness, the perfusion is changing. That's not normal. If you look at yourself and you look at what's happening to that patient, you're going, something's going on there. Why is that patient so pale? Why are they sweating? So even though you physically can't see internal bleeding, obviously if you have a look and you see some bruising and things like that, that'll give you an idea. But if that person's perfusion is changing, that's telling you that something is going on. And that could relate to anything that's going on in terms of shock. All right, so we can see it can result from a variety of diseases, states, and injuries. Affects the entire organism. Now, this is what's important, the classification. So I want you guys to put these terms in the back of your mind, so that way you get an understanding later on. So the first one we call hypovolemic shock. We all know that hypo means low. So hypo meaning low, and volemic is obviously a volume of blood or shock. And absolute means pretty much external. Okay, so we can lose our volume externally through hemorrhage and burns, typically. So that's one classification of shock. So just try to remember that one. Hypovolemic or absolute. Both are correct, whichever term you like to use. But it's virtually talking about losing external blood volume. So, as I said, from external hemorrhage or burns. Now, the next one's called distributive shock or relative shock. Now, that can be internal, and it is internal. So we're not seeing any external blood loss. This is happening internally. And with that, No, I'll keep going. I'll go through the 4 first. So that's the distributive shock. Next one's cardiogenic shock. So cardiogenic is relating to the heart. So the heart, for whatever reasons, become poorly perfused. It's not moving the blood and oxygen around through the heart. And that heart essentially itself is going into shock. It's not perfusing adequately. All right, so that's your third one. So you got hypovolemic or absolute, whatever term you want to use, is fine. Distributive or relative, whatever term you want to use, is fine. And then there's cardiogenic. Then the other one is obstructive. So there's an obstruction. When I look at all this, the 4 types of shock, I relate that to pipes and pumps. So some of it's to do with your pipes, which are your blood vessels, and the other one's to do with your pumps, like your heart. So pipes and pumps, that's how I think about that. Is that what you think, Cole?
Yeah, I do remember that. Yeah, pipes and pumps. Yeah, it's a good way to look at it. Yeah,
yeah, that's how I look at it. So yeah, pipes and pumps. Righto. So hypovolemic or absolute shock. It'd be nice to have the whiteboard because I like to do a few things on a whiteboard, but I don't have that, and I don't know how to use this one. So there's hypovolemic shock when the fluid is lost from the body. So it doesn't matter what type of fluid, be it blood, plasma, a fluid from burns. It's an absolute shock. So we're losing fluid from the body. So hemorrhage, dehydration is another one. So we have we're losing fluid through dehydration. So it's an absolute shock, and burns. They're typically a 3. So when we look at our signs and symptoms, we have to fall back on our history. Doesn't matter who we're treating, we always need to gather a good history to find out what's going on in the initial piece. So when we see our patient, we pretty much, like investigators, we've got to go through an investigative process first, and we need to gather our history. You know, what were they doing? Have they been unwell? What has changed? Everything like that's of great importance. So we start to fit little bits and pieces together to give us an idea of what might be happening to this patient.
Sorry, so that surgical emphysema, another way of being able to tell if...
What was that, sorry?
Surgical emphysema. You were going over before ways to sort of see if a patient may be going through hypovolemic shock. Is surgical emphysema one way to tell?
Do you know what surgical emphysema is?
I do. It's sort of retention around the skin. You can sort of see the skin and sort of air and sort of...
Yeah, so okay, so that has nothing to do with shock, essentially.
Yeah, okay.
Right, that's a little bit more technical, and it's relates to the respiratory system.
Yeah, rightio.
Okay.
Do you mean subcutaneous emphysema, not surgical?
Yeah, sorry, subcutaneous emphysema.
Subcutaneous, yeah.
Okay.
Yeah. Yeah, so that's more relation to our respiratory type conditions when we talk about pneumothorax, teaching pneumothoraces and things like that. So that's really totally different.
Yeah, right.
But here's some of the signs of history here. Vomiting, diarrhea in the case of dehydration. More than 9% burns can lead to a person going to hypovolemic shock, and trauma from external or internal bleeding. All right, specific signs to hypovolemic shock or absolute shock, as we've said. Dehydration, in children, you've either got the sunken fontanelles or increased skin turgor. Does anyone know what skin turgor is?
Is that the pinch, where you pinch it and the skin kind of stays up and sticks together?
Yeah, correct. So the longer it stays up and the slower it goes back down, is showing that recoil is not as good as what it should have been. So therefore, that area is quite dehydrated. It's always a good sign in dehydration. And just have a look at the skin texture. Just pinch that skin up and see how long it takes to retract back. That's a good indication. Another good indication of dehydration is get the patient to poke their tongue out. And if their tongue's all furry and looks dry, chances are they're dehydrated or becoming dehydrated along with skin texture. May not be sweating if the cause is dehydration. Sometimes they get past that sweating point. They've overcompensated. They just don't sweat. So they may not necessarily be sweating if they're actually dehydrated. So that's just another telltale sign. Cool, pale, diaphoretic. So their skin becomes quite cool, the patient becomes pale. And what's diaphoretic mean? Come on, guys, the layman's terms. Does anyone know what diaphoretic means? No? Sweating. Simple term for diaphoresis just simply means sweating. Okay, so if someone's cool, pale, diaphoretic, or clammy, they're the three telltale signs that a person may well be in some sort of shock. Tachycardia. Does anyone know what tachycardia is?
It's like abnormal fast heart rate.
Who said that?
Jacob.
Jacob, correct. Yep. Fast heart rate. Very good. So if we got those signs happening, pale, cool, diaphoretic, tachycardic, chances are patients go into shock. Tachypneic. What's tachypneic mean? So tachy, we know is fast.
Fast rate of breathing.
Correct. Tachypneic, shortness of breath, or dyspnea. All right. Then altered LOC, restlessness and combative. Why the altered LOC?
Loss of bleeding can cause a altered level of consciousness, obviously, and it can cause a lot of behavioural issues as well due to the lack of blood supply around the body.
Kind of. Can anyone else simplify that? Why would we have an altered LOC, restlessness and combativeness?
Lack of oxygen to the brain.
Pretty much.
Yeah.
The brain is very, very energy hungry. It relies on a lot of glucose, a lot of oxygen, all those sorts of things. When we're losing some of this stuff, all that, the red blood cells, the oxygen, all those nutrients that go along with all that, the brain is very, very sensitive. So you'll get this altered level of consciousness. You'll get this restlessness. And sometimes the patients can become quite combative because the brain is so irritable because they're not getting the oxygen and the nutrients that it needs. So there's a lot of the telltale signs there, and obviously a decreased blood pressure. So any form of shock in the main, there are other variants where that decreased blood pressure may not actually occur. But in the main, when we talk about shock, specifically hypovolemic type shock, they'll have a decrease in blood pressure. And that's why checking our vital signs and monitoring our patient is so important. This can happen very quickly. The body can compensate so far, but there's a point where they'll just, what we refer to as crashing. So they'll just crash. Everything will just happen all at once. We might have a patient that are showing some of these signs of shock, appear to be quite manageable, and then all of a sudden they just drop because our body's trying to compensate, but it can only do it to a set point. Do you want to add anything there, Cole?
Probably only thing I'd add really, and we haven't mentioned it there, the specific signs of hypovolemic shock, they're all good together. However, individually, one on their own, it's not really a good indicator of hypovolemic shock, but certainly all together, yes, you can probably bet your house on it.
Yeah.
Is
Go
this
along with
more
that.
common in kids? Like when they get sick, they compensate really, really well, and then they just don't compensate at all, and they can go really alert to just out of it quite quickly.
Yeah.
Well, that's children, Elise. Is that what you're saying?
Yeah, like so with my kids, I've noticed when they're quite unwell, they'll compensate really well at first, and then the change is quite quickly and quite sudden. So is hypovolemic shock common in kids? Like, do they experience it a lot more than, say, an adult would?
Yeah, look, what you're saying is absolutely correct. The kids seem to compensate well for a while, and they just crash. But the way I look at a child overall, generally, you know yourself being a parent, generally a quiet child is a sick child. So when they start getting a bit quiet and things like that, you can be pretty sure something's not right with them. And when you look at shock, you've got to remember too, particularly hypovolemic type shock, they don't have as much circulating blood volume as an adult does, so they can lose their volume in that fairly quickly, and they just don't compensate as well as we do. So you're 100% right in what you're saying, that with the kids, they can crash fairly quickly. So you've really got to be on top of that. But having said that, one thing with children you'll find is that when it comes to treatment, if we treat children quite aggressively, they tend to bounce back fairly quickly as well. So it's all it's all comparative as far as that sort of thing's concerned. But you're right, just got to keep an eye on kids. Their compensation mechanisms a little bit different to ours. All right, then the rapid thready pulse. All right, so the next one we're going to talk about here is distributive shock. So the first one was hypovolemic or absolute. So absolute sort of just saying, well, you know, they're losing that blood fluid or fluids, not necessarily blood, but fluids. So we'll have a look at distributive shock, and this is all about pipes, pretty much. So distributive shocks as a result of blood vessel dilation, leakage due to increased permeability, blood pressure and circulating fluid decreases. So the way I look at this one is that if we have a bucket that's, you know, full of water, and then we'll compare it with a bucket, but that bucket's actually gotten bigger, but it's got the same amount of water in it, it's going to take a lot longer to be distributed through an area. And that's how I look at this. I always look at, I put in perspective a bucket of water, so, or a glass of water. It doesn't matter what it is. So you just imagine you pouring some water into a plastic cup, and that all of a sudden that plastic cup became twice its size, but there's still the same amount of water. It's going to take a lot longer to get that fluid around to where it needs to go. But the same amount of volume's there. The volume doesn't change. It's just the size of the pipe. The pipe's got bigger. So it lessens that flow. And that's how you look at distributive shock. One of the things with distributive shock, if we have a look at that kitty there, what do you think's wrong with that child?
It's an allergic reaction.
Correct. So It's a bit more than allergic reaction. What's the other term for it when it goes beyond that?
Anaphylaxis.
Anaphylaxis. Okay. A lot of students, when we talk about these 4 types of shock, they'll have hypovolemic shock, anaphylactic shock, whatever. Anaphylaxis is part of the distributive shock. Okay, so when we ask for the 4 types of shock, we want to be specific. So we've got our hypovolemic or absolute shock. We have our distributive shock. Then we have our cardiogenic shock. And then we have the last one. No, I can't remember it off the top of my head. It was not neurogenic. What's the other one? That's how bad my memory is.
Cardiogenic, did you say?
What did I say?
Cardiogenic, is it?
Yeah, I said cardiogenic.
Oh.
What's the other one?
Hypovolemic, cardiogenic.
That's how bad. Anyway, we'll get to that because it's the next one on the slide, I think.
Yeah.
So distributive shock's the result of blood vessel dilation. Dilation just means that it's gotten bigger. And leakage due to increased permeability, blood pressure and circulating decreases. All right, so that's what causes that. That's distributive shock. Neurogenic shock, anaphylactic shock, septic shock. I'll just go back and we'll just touch on them. Go back one. All right. So neurogenic shock, what do you think neurogenic relates to?
The brain.
Yeah, so the nerves, okay. What would be a good example of, say, neurogenic, as far as perhaps an injury is concerned? Can we think of any?
Could it be like a head collision in like sport or?
That's more of a head injury, not necessarily.
Spinal injury?
What was that?
Spinal?
Yes, correct. Okay. So that's one that's very good, spinal injury. Then we talked about our anaphylactic shock. What about septic shock? Does anyone know what septic shock is?
Is that from blood infection, sepsis?
Correct, 100%. So, yes, it's a blood infection. Sorry?
I've had that.
Oh, there you go. So, yeah, not real good, is it?
No, it's not a fun time.
4 years ago, had sepsis from a surgery, and he's now got permanent nerve and joint damage in his hand. He's got to have a potential amputation of his hand due to having the sepsis missed. Yeah,
so essentially septic shock affects your vascular system, dilates, becomes infected, it needs to be treated with antibiotics and various things. But it is a serious type of shock that we need to identify as paramedics, and we need to be have that background knowledge that this person's going to shock. So we've said it's a blood infection. So what would be a sign of infection, do you think?
Raised body temperature.
Yep, definitely. Yep.
Elevated heart rate.
Yep, exactly. Anything else?
Sweating, maybe, depending on what level they're at.
Yep. So what we're doing here is we're getting you guys to start thinking about what the person looks like and why it's happening. And you've got some of the answers there. High temperature with sepsis, with infection. The tachycardia goes along with it. So the fast heart rate, the blood pressure starts to drop. With our septic shock, it doesn't generally happen straight away. And I was heading down that road myself. I had cellulitis I didn't even know I had. I initially thought I had the flu, or the shakes, the rigors, the increased.
That's what I had too.
What was that, cellulitis?
Yeah, in my leg, and then I left it so long because it wasn't very noticeable. It was just a tiny spot, and then within 2 hours it went from a spot to a foot of redness, and my leg was going to explode, and I was very, very sick. Yep,
that's what happened to me. I didn't even know. I thought I had the flu. And initially my wife said, what's that, all that redness on the back of your leg? I couldn't see the back of my leg. And I finished up with cellulitis. So it can be easily missed, but you would have to gather a history. It's signs, the signs that you just said there, Alicia, that you had this red mark that sort of moved on and developed to something worse. So there's some of your signs and symptoms, and that's what you need to look out and be aware of with your patient. Gather some history. Have you noticed anything different? Oh, yeah, I noticed this red mark on the back of my leg. Oh, when this happened, oh, I've just noticed it, but the last few hours I've been feeling really sick. They're all telltale signs, and history taking, gathering that information and putting it together with your signs. The temperature.
I actually called an ambulance and they nearly refused to take me and put it down to hand, foot and mouth. And then when I got there, I was in critical care for 5 days. And they nearly left me at home.
Oh, that wouldn't have been good. That wouldn't have been good.
That's almost medical negligence.
I just begged.
Well, hang on, Jacob. It's not necessarily medical negligence. It's the fact that they clearly didn't gather enough information and bits and pieces.
I had kids at home who had hand, foot and mouth, and I had symptoms of it, and all I had was this little red spot on my leg, and the pain was incredible.
Yeah.
And they're like, it doesn't look like anything other than that. And I'm like, nah, something's really, really wrong. I need to go now. And I had to beg, and thankfully I did, and they took me. But yeah, if I'd have just said, okay, no worries, I probably wouldn't be here, or I'd be very, very sick.
We used to have a saying when we were on the road. You remember it, Cole? You call, we haul.
That's right. That's right.
I look, Alicia, all seriousness, if a person wants to go to hospital, we take them to hospital,
Yeah. Like, I get where they were coming from.
Yeah.
Serious, and I didn't have a visible temperature, but I had rigors.
Yeah.
And I had the vomiting and diarrhea, and they just thought maybe it was gastro mixed with hand, foot and mouth, monitor at home. And I was like, it's just, I really don't feel great. I need to go. And
I mean, at the end of the day, you're the patient. You know how you feel.
Yeah.
And if you're in a position where, hey, look, I can't get myself to hospital, I don't feel really well here. That's why I called you for, and that's why most people call ambulances. Yes, there's people that, malingers, I guess, to put it fairly, but my experience.
So there's a really good chance that they get called for nothing.
Yeah.
Yeah. I get it.
Yeah. But yeah. Anyway, we'll move on. So you get the picture of where we're coming from with all this, and it'll start to fall into place once you do that workshop. Once you start playing with the tools and gathering histories and doing, it'll all sort of fall into place. So if you have a look at it here, the distributive shock, the body is a vessel, and that was the bucket I was talking about. See how we got that nice normal vessel there, then all of a sudden that vessel gets bigger. And there you go. So these are leaking. So it's the same bucket, but it's just changed. It's gotten bigger, and it's a lot harder to pump that through. So the signs and symptoms of distributive shock mechanism suggests vasodilation. Now, with a spinal cord injury, what we've got to be careful of with that is, I'm not sure if you're aware of it just yet, but essentially our body needs a blood pressure of greater than 80 systolic to perfuse our vital organs. So we remember what the word perfusion is, getting oxygen and so forth to our vital organs. So that's our perfusion. So we need to maintain that perfusion. If our blood pressure drops below 80%, that perfusion decreases markedly, and there's a risk of those organs shutting down, in particular your kidneys. Now, when someone goes in a spinal shock, they'll have a degree of vasodilation. They will have a drop in their blood pressure. But with them, a blood pressure of about 90 is still quite acceptable. Okay, so they haven't gone into that dangerous area of not being able to fuse their vital organs. Generally, they'll get that vasodilation of around 90 systolic. So essentially don't really need any volume replacement in that as such. You can maintain that. Yes, they're a bit hypotensive, but they're able to maintain that blood pressure. So that's a little bit of a little bit different when it comes to a spinal cord injury. There will be a drop in blood pressure, but not enough to be overly concerned about unless it falls below that 90 systolic mark. Drug overdoses, of course, we tend to have a drop in blood pressure with that. We've spoken about sepsis and anaphylaxis. Warm, flushed skin, especially in dependent areas. A lot of that warm, flushed skin comes into the septic shock realm. That's where we see that. A little bit in anaphylaxis, not so spinal cord. And bearing in mind, as Cole said before, there's so many variants in our signs and symptoms, and this is just one of them. You may not get all of these signs and symptoms. Who said that? Oh, who said that?
I think it's Sarah.
Oh, Sarah, I didn't know she was here. I haven't seen her. Where have you all? Hang on. There we go. Yes, Sarah, the answer to that is yes and no. What was your question again? Well, what have I done there? Something bad's happened. Shit, no, I'm back. I've got to be careful. So, Sarah, the answer to that is yes and no. Not all of these patients, particularly our anaphylaxis, spinal cord injuries, necessarily need fluids. In the case of our septic patients, more than likely they would, along with some what we call vasopressors that increase cause some vasoconstriction and improve perfusion. Well, that's the theory behind it all. So the answer to that is yes and no. But some of these patients we don't want to overinfuse. Lack of tachycardia. And that's right. In that, again, tachycardia, you may not have tachycardia in, say, the case of the spinal cord injury. The anaphylaxis, you most certainly probably would. Drug overdoses, not necessarily. Your septic patients will have a degree of tachycardia. So it's not a reliable source. And then you've got to take into consideration too, certain patients might be on certain medications that even block tachycardia, so they may not even be present in those patients. Signs and symptoms of the anaphylaxis, we've got the angioedema, the wheezing, shortness of breath, hives, and decreased LOC. Increased temp with sepsis just gives you a bit of an idea. So, is there any questions on the distributive shock? Does everyone understand the difference now between a distributive shock and a hypovolemic shock? Anyone? Nodding? Don't get many responses.
Vaguely. I'll have to research it and read it more, though.
Right, that's all good learning. So, Sarah's got it. Sarah's got it. All right. As I said, it can be a quite confusing topic.
But it all fits into place. It's, penny drops. It was confusing for me at first, and and the penny dropped somewhere down the track. Eh?
I'm trying to reply to Sarah, but every time I hit that button, that other thing comes up. Right.
Go into chat. Have you gone into chat?
Yeah.
Up the top there?
Yeah. That's what I had up. Now what's happening? Right. Oh, that's better.
Yeah.
Right. I'll leave it at that. Otherwise, I'm going to confuse myself. Right. Okay, cardiogenic shock. That's our third type of shock. So when we come to answering our questions, the 4 types of shock: hypovolemic, distributive, cardiogenic, Well, that's what the last one's obstructive. They're the types of shocking answers. We don't want to see anaphylaxis or septic shock. We all know that that's shock, but we need to know the types of shock. Okay, the category of shock. That's what the question relates to. All right. Cardiogenic shock occurs when the heart is unable to deliver adequate circulating blood volume. It goes back to perfusion. What is perfusion? Jacob, what was perfusion?
So perfusion, sorry, I...
Rita, what's perfusion? I think you're on mute. Rita, you're on mute, I think. Can you hear a Col? No?
Scott, she's on mute.
That's what I thought.
Is it fluid through the circulatory system to help with the tissue development?
I couldn't hear that.
No, I kind of missed it too.
That's all right.
There's a lot of background noise for me.
All
Yeah.
right, Sarah, do you know what it is?
Can you guys hear me? My mic can't work very well. Can you hear me?
No. Don't worry. Don't worry. So we'll just recap. Perfusion is inadequate circulating blood volume. Okay, that's all perfusion means. Inadequate circulating blood volume. All right, so just remember that term. You'll never forget that term. So cardiogenic shock. Feedback. Is AMI, so acute myocardial infarction, arrhythmias, cardiac tamponade, tension pneumothorax. When you're dealing with your trauma scenarios and things, and when you go back to your workshop 1 and 2, you'll be talking about, in particular, tension pneumothorax. It's also part of your patient assessment when you do your primary and secondary assessments, tension pneumothorax. So it's all related to what happens. So the pneumothorax isn't the heart per se, but what it does when the pneumothorax starts to tension, it starts to shift your major organs like your aorta and so forth across to your heart, which in turn causes your heart to essentially go into shock itself. And that's why we need to remove that tension as it starts blocking up the pipes of the heart. So your aorta and things like that, the major blood vessels start to become constricted and block up. And that's why they include tension pneumothorax as part of the cardiogenic shock. And that's why it's there. And it can also be part of obstructive shock as well. Some of these types of shocks can overlap, and that's one of them. So there's a picture of the heart there. All right, chief complaint. So again, we talk about signs and symptoms. Remembering back, signs is something that we can see. A symptom is something that the patient complains of. All right, so part of your signs and symptoms is chest pain, dyspnea, and tachycardia. Sometimes with your heart, it can also be a bradycardia, and obviously brady means slow, or excessive tachycardia. So therefore, your heart isn't pumping the way it should. Remember, we've got to pump anywhere between 5 and 7 or 8 litres of blood around the body. And if it's not pumping effectively, the heart's not working effectively, and therefore it's going to cardiogenic shock. Dysrhythmias, so there. Question?
Oh, no, it's only me, Chris. I just put on message on chats just for a brief summary of 4 main types of shock. So if they have a look at them, that it's just a brief summary, but it sort of hunks it all down into 4 brief points.
Oh, good.
Of the 4 different types of shock. There's also one there, the difference between hypovolemic shock and cardiogenic shock too. There's a bit of a explanation there on both as well that I don't know, might find handy or you might not. Just discard
It'll
it.
be handy.
Yeah.
All right. Signs of congestive heart failure. So jugular vein distension, and you'll hear about that talked about when you do your primary and secondary assessments and the importance of it. So your jugular vein distension can relate to things like in a trauma scenario to your tension pneumothorax. It's a late sign, but if a jugular vein distension with a shortness of breath and so forth as a result of trauma, chances are they've got a pneumothorax that's beginning to tension and they be quickly heading towards that cardiogenic shock scenario. Pulmonary edema, so pulmonary just meaning your lungs, edema meaning fluid on the lungs. You know, you guys probably won't see a lot of that. And over the years, even in ambulances tend to see less and less of pulmonary edema. Years ago, Colin and I seen many hundreds, if not thousands of cases and treated thousands of cases of pulmonary edema. But a lot's changed as far as medication and that's concerned, and it's far better controlled these days in the pre-hospital setting. So you don't really tend to see as much of that as we used to. And pedal edema, pedal obviously just means foot, so fluid around the ankles and feet. And of course, that's relating to your circulation. Signs of cardiac tamponade. Again, it's not something we would generally see in the field. You know, I've seen a bit over the years, but you wouldn't say it's a lot. It's not something you come across on a regular basis, but it's most certainly there. So chest pain radiating from the chest, decrease in blood pressure, anxiety, dizziness, shortness of breath, increase the respiratory rate, decrease the LOC. That could cover a number of different things. Oh yeah, I got that. That's good, Col.
Yeah, I'm just throwing some things in there that folk might want to just have a look at, I guess, at some point, you know. It just kind of summarises some of these slides, some of them.
Okay, and the last shock I'm going to talk about is obstructive shock. So this is due to obstructive of blood flow in the vessels of the heart. And that could be anywhere. Common causes similar to cardiogenic shock, and they often group together. So, as I was saying before, obstructive and cardiogenic shock can overlap, depending what's wrong with the patient. So look for signs and symptoms of cardiac tamponade, tension pneumothorax, and a pulmonary embolus. Recognising the severity, and this is fairly important. So remember that we said that we compensate fairly well to a degree. Then we go into that decompensated shock where they're not compensating as well as they should, and things are starting to get a little bit bad. And then irreversible shock. Once we get to that stage, it's not real good. Organ failure, cell death, things like that. So we'll just have a look at the compensatory shock to start with. So our heart rate increases, respirations increase, pulse becomes weaker, the cool, clammy skin, anxious, restless, combative, thirsty, and weak. So when we look at what's happening there, if we make sure we carry out our observations and monitoring our patient, and that's why we tend to monitor patients on a fairly frequent basis. So if you have a patient that doesn't appear to be very well and you've got concerns, you should be monitoring your patient's vital signs every 5 minutes or thereabouts. So if you see that kicking around a question somewhere, or you do your patient management, and when it comes to monitoring, you would say monitoring patient signs, respiratory rate, blood pressure, etc., every 5 minutes. You know, that's important. So that way we know that you know that you're going to constantly monitor the patient. So when we look at that, we call that stage 1 and 2 hemorrhages. Stage 1's a blood loss of between 500 and 1250 mils, or 5 to 20% of the blood volume. Decompensatory shock, very weak or absent pulses, severe drop in blood pressure, altered mental status or unconscious, slow breathing or apnea. They may stop breathing altogether. Then when we look at the blood loss there, 1250 to 1750 mil plus, or 25 to 35% of blood volume. Then irreversible cell death, organic system failure. And that's what we say, if blood pressure in an adult drops below 80, we start to have this organ failure, washout and hemorrhaging all over. 1750 mil blood loss, 35% of your blood volume. So, you know, it's fortunately most of it doesn't happen straight away, unless, of course, it's a severe arterial bleed that we can't control and things like that. You'll lose your blood volume very, very quickly. If you have someone that's you know, has an arterial bleed, there's no good thinking about doing CPR and all this sort of stuff. You need to get that arterial tourniquet on. Initial assessment, we check our airway, check our breathing, check our circulation, disability, then expose body surfaces. When we're talking about exposing body surfaces, we generally talking about that in trauma. Then our detailed physical examinations, all our vital signs. So we want to do our heart rate, we want to do our blood pressure, we want to do our GCS, we want to do our saturation of oxygens, we want to do our BGL, or glucose level. You know, there's things there that you may not necessarily have to do, like a BGL if they've got a GCS of 15. Not overly important. If they're sitting there and they're breathing and that okay, GCS 15. So we go through that, but certainly our blood pressure, heart rate and things like that, very, very important. All right, so our vitals, there we go, our pulse, respiratory rate, blood pressure, and orthostatic vital signs to be taken when the patient is supine, sitting or standing. What that means is when we check for blood pressures, we need to get the different stages if we can. You don't always have to do it, but essentially as our body starts moving, so too does our blood pressure. So essentially your blood pressure should be slightly higher when you're supine as opposed to sitting or standing. Why? Because there's a shift in that blood volume, which is going to shift, not so much your blood volume, but a shifting in your blood and movement to certain areas of the body, which is going to change your blood pressure to some degree. I'm sure it's happened to you all. You've been in bed of a morning, you get up in the middle of the night and you feel a bit wonky, and that's because of the change in your blood pressure. And that's what we find a lot of our geriatric patients have: falls in the middle of the night. They'll get up to go to the bathroom, they'll get a sudden drop in blood pressure, then over they go. So it's always good to just get into a practice of just checking blood pressures. And when you go into your workshop, it's a good thing to just get into that habit of checking at least supine and sitting. You can do it standing as well in the classroom, and just practice taking blood pressures. And remember too that when you take a blood pressure, it's a skill, and it's a skill that you'll learn, but it takes time to become competent at it. So when you're in that workshop, just practice your blood pressures. Take your blood pressures on each other and just practice it. It is a skill. Isn't it, Cole?
Absolutely. During the Vivas, some of you might know, I've reintroduced the basics, and all those things we cover in there again, because if you're not doing it all the time, you can forget. You de-skill very, very quickly. Very quickly. Yeah. Well, look, I've punched a whole heap of information into the chat bit, the meeting chat. So if you guys just want to just copy the whole lot and paste it into a Word document, you may find it handy a bit later on down the track, or indeed now. So I wouldn't try and write it down. There's probably too much there. So just cut and paste it into a Word document if you want. But it's all there for you if you need it.
All right. And the last part's our secondary assessment. So you'll do a primary assessment, you'll learn how to do that, and then we'll have our secondary assessment. So we're looking for signs and symptoms and may assess in categorising the type of shock. I think your hemorrhage or your absolute shock's fairly simplistic. You can see it. If it's burns, dehydration makes it a bit harder, but your history is going to help determine that one for you. Then you've got your relative shock, which is your distributive shock, your anaphylaxis, your sepsis, your drug overdoses, things like that. Again, a good history should put you on the right track as far as determining what type of shock that is. Then our cardiogenic or our obstructive one, you know, it relates to the heart and the pumps. Again, the history is important, and when we throw tension pneumothorax into that, well, that's in relation to a trauma, so it's got to be fairly significant, and it becomes fairly obvious. Yeah, treatment. Where is our treatment? There is no ambulance. That's a treatment. That's it. Well, that's a PowerPoint on hemorrhage and shock. I think it's probably giving you a good insight and step up to where you're heading with all of this. And it's probably timely that we've introduced it, because shock can be a difficult subject to get your head around if you're not used to it. But Cole, do you want to add anything in here?
No, not really. I think that's probably enough to get your head around initially. As I said, I've posted some notes there, so you guys can have a look at them or not. That's fine. They may help you understand it if you're struggling with it a bit, which, to be honest, I don't know about you, Chris, but I did first off.
Oh, yeah.
Yeah, I struggled with it a bit, but I can't remember what tipped me over and made the penny drop for me, but something did. So, yeah. Maybe it's something I read somewhere. I just can't remember.
I think what makes a penny drop is that just asking the right questions, getting your signs and symptoms right, understanding, as Cole said, what's abnormal from the normal. And once you get that and start seeing that and putting things into perspective in relation to obtaining a good history, and putting all that together, that's when the penny starts to drop. And, you know, you're either treating one or two things in pre-hospital care. You're either treating straight out trauma or you're treating medical illnesses. So they're your two main things that you do mostly. But having said that, we've got psychiatric type things, so mental health, pediatric and geriatric and things like that. So there's all these subsections of what we do in the pre-hospital environment. But as far as this sort of stuff's concerned, that you can see by that there's three of those four types of shock are pretty much medically related or cardiac. So you've got cardiac relation, you've got your medical with your anaphylaxis and your sepsis and your drug overdoses, and then you've got your hypovolemia. And essentially it's the external internal hemorrhage that more than likely is trauma related. So if you break them down to that categories too, it makes it a bit easier when you're trying to determine what's wrong with the patient. So if it's not trauma related, it's clearly going to be medically related. But at the end of the day, we're looking at signs and symptoms of how we're going to treat these patients. And that's why it's important. As I said, with fluids and things like that, what we used to do years ago, we no longer do today. Okay, so a lot of things too that we use in the pre-hospital care environment settings come from the military. And again, a lot of those practices are no longer there with some of the things that they used and we used, and we've now gone back to doing other things. But having said that, there's still things in there that we still use. So there's good and bad, and it's how we learn, which is a good thing. So when we put it all together, the key components for you guys, because as Col said, you can't remember everything, you won't remember everything, unless you're practicing it and doing it all the time. You're probably going to forget more than what you've actually learned, unless you're doing it all the time. So what we really need to do is simplify it and break it down. And that's what we're trying to achieve here, so you guys get a better understanding. So what you need to know is the normal from the abnormal. And that's why Col said it's important that you know what a normal blood pressure is, thereabouts, give or take. What a normal heart rate is, give or take. GCS, things like that. That's why it's so important, because when there's any variation of that, that's telling you something's not right for whatever reason. Okay, so if you're being on a run and your heart rate goes up to 130, well, that's quite normal. You want your heart rate to go up. You want exercise, so you want to push hard a little bit. But if you're sitting and doing nothing and all of a sudden you've got a heart rate of 130, something's not right. So we need to think what's normal and what's not normal. And when we start going, what's not normal, why isn't it not normal? What's going on? Have a look at your patient. I said before, perfusion determines treatment. Perfusion, is adequate circulating blood volume. We're treating perfusion. We're treating what looks normal. All right. If a patient is confused or becoming confused, their level of consciousness is dropping off, their heart rate's increasing, their blood pressure's dropping, something is not right. We need to find out what's not right. We need to go about treating it. Is there any questions? I like questions.
Not so much in relation to the shock and stuff, but I know there's a practice pharmacology exam. Is there any other practice exams that we can do, or?
I think it's only those ones, I think.
Yeah, I think it is only the pharmacology, Chris. Yeah.
Yeah, I think so. So this is why it's important that you understand the different types of shock. Say, let's go back to not anaphylactic shock, but distributive shock and anaphylaxis. Anaphylaxis is a classic example. We don't normally treat anaphylaxis with fluids. What do we treat anaphylaxis with?
Adrenaline.
Yeah, okay, so we treat it with adrenaline. What does adrenaline do?
Raises your blood pressure, dilates your arteries and veins and stuff.
So it increases your blood pressure.
Increases heart rate.
Also opens up the ways a bit more.
So it increases your heart rate, constricts your blood vessels that are already opened up and dilated. So we want to constrict it. Yeah. So that's what adrenaline does. So therefore, essentially, there's no need for fluid in that regard. That's what adrenaline does, and it does it fairly quickly with anaphylaxis. It's reversing that type of shock. Remember, anaphylaxis works on the immune system, pretty much. It's an inflammatory response. So they're the responses that you're getting. So in adrenaline too, with anaphylaxis, I'll have a shortness of breath, wheezing, things like that. The other thing adrenaline does is a bronchodilator. It opens up all those airways. So it helps with their breathing. That's the importance of knowing your medications, right, and what your drug does for that particular thing. There's other forms of shock that you wouldn't use adrenaline for. External blood loss, for argument's sake, adrenaline's not going to really do too much for that. it's stopping the bleeding, and they require, plasma or blood cells or whatever it is they need to replace that initial blood loss. So you just got to think about what our drugs do and what sort of fluid replacement we need to assist in these forms of shock. Burns is very important. We need fluids for a burns patient. We need a certain amount for a burns patient because they've lost a lot of fluid. Same with dehydration. We need to rehydrate these patients. So fluid's something that we use for them. Septic shock, you use a mix of fluids and what we call in hospital vasopressors, and obviously antibiotics and things like that. So we're treating that sepsis in a different way, but we need to understand it. So for us in the field, as far as sepsis is concerned, all we can really throw at that in the initial stages of fluid. And once they get into the hospital, they'll get the rest of the treatment. We just need to know what sits in the background, how we go about treating those things. But the key to it all is your signs and symptoms and your patient management. Just remembering if someone's got a low blood pressure, we need to get their posture right. We need to check their SpO2. If they're saturating poorly, under 94%, they clearly need some oxygen. Again, not everything, you don't have to have all the signs. You might only have a couple of signs. It could be in that compensatory stage. That shock may be just starting to evolve. But we just need to be mindful that we're picking up the little telltale signs along the way so that in the event the patient does deteriorate, we know how to treat it. Does that make sense? Everybody? Nobody? Yep, got a few head nods. Yeah. So that's good, and that's why it's just so important that we get to that stage. What we find with our students is once we start getting to the patient management side of things and scenarios, that's where you fall down a little bit because we're stepping into unfamiliar territory. The innate and phys, I know a lot of some of you guys were concerned about innate and phys. That's the easy stuff. That's the stuff we can just get out of the textbook and things like that. That's the easy bit. But once we start dealing with our patients themselves as real, and when you go to your workshop, they'll be doing scenarios and it's going to be real, and that's what you need to pick up on. And it's not always to do, and it's a lot harder to do when you have to actually put answers down on paper. So when we do the scenario things, you need to read the scenario, you need to match it up with the signs, and then you need to come to that conclusion on how you're going to treat that patient, or what you may think is wrong with that patient. And if you go down that road, you've just got to be careful. That's not the road where you're going to take yourself into a bit of a rabbit hole. So you just want to make sure you read your question carefully, have a think about it, have a look at the observations, because there's so many variants in there. But if you pick up the little subtleties and the little changes, it's going to make you think. So again, when Col and I mark all this stuff, we look at how you're responding to those sort of questions. And that's the key, because if we know that you've got a fair idea of that you know how to do it on paper, the chances are you'll have a fair idea of how to do it in the real scenario. But when we see stuff that just doesn't make sense, or it's lazy, we go, well, hang on a minute. We need to be certain that these guys know what they're doing. So it's going to be a whole new ball game. And that's where Col and I sort of have a bit of a closer look. And that's why we're trying to prepare you for this. Once you get to the workshop one, things will start falling into place. You'll be taking pulse rates. You'll be doing blood pressures. You'll be doing patient assessments. You'll be doing your ALS, CPR and things like that, using defibrillator. All fall into place. But to have this little bit of background knowledge before you go in is probably a good thing, particularly when we talk about subjects like shock. It's very, very important to get that understanding of it. That's where some of the students struggle. So do you have any questions at all?
I've got one. It's not related to this topic, but we obviously learn cannulation. Now, looking at our scope within medications, we can't give anything intravenously. Is there a reason that we learn how to cannulate when we can't give medications intravenously?
Well, I suppose the answer to that is that prior to the degree, the diploma covered that, and it still does. So they haven't taken that out as a skill. So I think one of the main reasons, there's nothing prohibiting you from, once you've learnt that skill in practice, of actually cannulating. Yes, you're right, there's certain medications that you can't give intravenously, but fluids and setting up TKVO, to keep a vein open scenario in a cardiac arrest, you're certainly able to administer fluids. And cannulation, sometimes you'll want to put a cannula in case the patient deteriorates. If the ambo has turned up, well, it's sort of already in place. So it's always been part of the diploma course. So it's a skill that you learn. I guess that's all I can say on that. I know there's certain drugs that you can't administer.
So we'll be able to hang a bag of Hartmans, for example, with a diploma accreditation.
What's that?
So as a diploma qualified, we can hang a bag of Hartmans or hang a bag of saline.
I believe so, isn't there, Col?
Yeah, that's about right.
Yeah, I think that's part of your scope of practice. I think you can do that. If you were to work, say you get a diploma, you to work at one of the events, say a music festival, you might say, oh, look, you can just pop a line in that patient, and IV in that patient. So it's a skill. When you look at IV cannulation, it's a skill. And that's what they teach you. They teach you how to depress a tension pneumothorax, for argument's sake. That's part of it. Do you do it regularly? No, I've probably done a handful in 40 years. It's not something you do all the time, but you know it, you do it. Yeah, I mean, that's just a skill. It's not something that you need to get too excited about. And if you were progressed to becoming a registered paramedic and work for a service somewhere, you'll already have that skill. So, any other questions? I'm expecting good answers when I see your papers, modules, by the way, guys, on shock. If I see anaphylactic shock when we want the 4 shocks, I won't be happy. We know our 4 shocks. What are the 4 shocks? Come on.
Hypovolemic. And
hypovolemic.
You've got your cardiogenic.
Cardiogenic.
Obstructive and
obstructive. And one more.
Septic.
What was that?
Septic?
Nah.
It's hypovolemic.
What was
shock.
that?
Hypovolemic shock or adaptive.
Hypovolemic. Yeah, we already said that. So, hypovolemic. Cardiogenic. Obstructive. One more. Sarah. Distributive shock. Correct. Okay. What? Tell me, give me 1 or 2 that fall under distributive shock.
Anaphylaxis.
Anaphylaxis. What else? Everything. Septic. Yep. What else? Come on. Yep. Neurogenic. Yep. Or spinal shock. Yep. You can probably throw drug overdose under it. So it's good. Which ones would fall under hypovolemic shock? Come on.
Anything where blood loss is concerned.
So hemorrhage?
Stab, hemorrhage, internal bleeding, ectopic pregnancy.
Yeah, internal bleeding.
Amputation.
Yeah, well that's hemorrhage. Come on, a couple more things.
Post-surgery complication.
Nah, what else? Nah. Think about trauma. Or I don't have to think about trauma. There's two others. Burns, yep, 100%. Dehydration, perfect. Perfect. Okay, so they're your subsets under those two main ones. All right, what about cardiogenic? Remember, some can overlap too. Cardiogenic. Think about the heart. AMI, very good, yep. What else? Yeah, heart attack. AMI, yep. Don't think about it. No, who said that? Sarah, emotional or physical stress. What's that all about? Remember what I said earlier? Emotional. It's got nothing to do with shock. Me every day. Ah, you're right. Okay, guys. Has everyone enjoyed today's session? Hypotension. Yeah, well, that's part of it. Oh, they're quite more. Hypotension. All right. What do you reckon, Cole?
Yeah. Everyone happy with that? I mean, anything you'd like more to know, or do you want any more information on some of it?
It's a good.
Because I've got a ton of information here. If you need to have any more information, a bit like the stuff I've pasted in there from my notes. Good question. I'm not sure where the recording's available. All I know is I hit the record button. Now, what happens after that?
I don't know.
Oh, yeah, I'm not sure either, but I'll find out. I'm not sure where it goes, where it stays. It goes into the cloud.
Yeah, probably.
Like everything else, and then disappears.
Yeah, where do we actually find like the recording? Because I couldn't find the last one that you did.
That's because I didn't record the last one.
Oh.
Yeah, that'll do
it. Yeah. I had a momentary memory lapse. That's lasted for about 3 weeks. So, yeah, sorry about that. But
you recorded this one then?
I think, someone reminded me earlier that asked me if I'd started the recording, and I hadn't, but I did when they reminded me. So this one, yeah, it is recording, and it is still recording.
Yeah. So where did you find that recording?
Yeah, look, I'm not sure where it goes. I'll find out, but
I think once the call ends, it'll give you an option, Cole, because you've recorded it, where it will go and where you can save it, and then you'll have the option to, I guess, upload it into Canvas from your side as an instructor.
Oh, okay, cool. Well, thank God someone knows what to do out there. Thank you for that. Oh,
okay. We'll wrap her up.
I think so. Yeah.
Okay. Yeah. All right, guys. Thanks for joining us today. Hope you got something out of it.
Thanks for doing it.
You're all very welcome.
Yeah. Would anyone like something new next week? Oh, sorry, the week after, the following fortnight? Any subject you'd like particularly? Or we just pluck one out?
What about like things in the hemorrhage? You know what I mean? Like where to find, because isn't every Australian ambulance like the same setting out of where things are, for example? You know what I mean?
I think they vary slightly from state to state.
Okay.
Yeah, yeah. And New South Wales ambulance doesn't exactly have a list where everything goes in certain cupboards, I don't think. So yeah, it changes a little from state to state.
Topics for the next one. Are we able to go?
Sorry, someone's got a radio going and you're getting cut out, Jacob. Ah, there we go. Radio's gone.
So going off the cardiac event sort of type of things within, like I'm quite sort of interested in a cardiac sort of side of medical episodes, I suppose you can call it. Can we look at maybe different types of ECGs and placements of ECG leads and stuff like that?
Oh, that I think that's a bit too early on, Jacob.
Yeah. Okay.
Yeah.
Yeah.
What we want to try to do is prepare you for your workshop one, basically, and most of that relates to your patient assessment, your secondary assessment, monitoring observations, understanding shock. We want to prepare you to go into that environment first, and that way, when you go in, because you'll hear this presentation again, but you're going to have a better understanding because you've listened to it today, and we've been able to point you in the right direction as far as some of the signs, symptoms, and all that sort of things concerned. So I guess what I'm trying to say is we don't want to put the cart before the horse. A lot of these online sessions, generally speaking, we either have a massive big group, not massive big group, but a group where you're all at different stages of the diploma, whereas most of you guys, just looking at who's joined us today, you're only in the early stages prior to workshop one. So we essentially can try to cater for you guys, given that mainly you guys that are turning up to, which is really good. And that doesn't mean to say the others aren't interested or anything like that. But I've just noticed thus far it's been you guys have been turning up. So I think for the most benefit, you guys will get the most benefit out of these. And if we can just keep within that scope till we get you up to your first workshop stage, and after that we can work into the other things like drug dose calculations, pharmacology, ECGs, things like that. But for the moment, I think if we stick to the basics and get you to have that understanding of that, and then once you start, patient assessments and monitoring vital signs, you'll get a better understanding leading into all those other things. So I think we just keep on track there.
What I've got here is
I'm going into workshop 2 at the end of the month. What should I expect in that workshop? Because my workshop 1 was pretty bad.
Don't get too worked up too much about the ECG side of things. In general terms, they're fairly basic, and it's a fairly a brief overview, really, into ECGs and things to look for. But there's a good app if you want to practice. I'm just trying to find it. I've got it on my phone. It's really good to practice. I just got to find where I've put it. Put the bloody thing here. See what happens when you get old? You forget everything. I've
got a PowerPoint here on drug dose calculations. That's some 20-odd slides. If for next fortnight, if anyone's interested in doing drug dose calculations. Yeah.
Who asked? Was it you, Sarah, that asked me about? Yeah. There's an app, and I think they're called flash. I don't know if it's just called flashcards, but they're on the heart, and what it does, it gives you a lot of the different ECGs, but it tells you about them and how to recognise them, and they're flashcards, and it really gives you some good information. So I'm pretty sure, I think they're just called flashcards. So if you look up ECG apps, you should be able to find that one. At the Play Store. ECG interpretation. There we go. Yeah, look, there's several apps on there, Sarah. If you just look at them, I'm sure you'll find one that you'll probably like. Does that help? Yeah. No, they're really good.
Okay, so next fortnight's one will be drug calculations. As I think most of you guys were pretty happy with that. So is that all right? Yeah, I'm just going through the slide now. It's actually pretty good. It really is, and it's quite easy to follow. Yeah, it is.
Are these PowerPoints that we do within these team meetings accessible for us to look at in the future?
Yeah. You sure can. Yeah, absolutely. And this slide, I think Sonia's already put this particular slide presentation, hemorrhage and hypovolemia. She's already put that up on the canvas somewhere. If you can't find it, it's probably best to give her a ring. But I know she posted this one and the last one we did. But as I say, I'm not sure where, and I'll ask her to post the drug dose one as well. Okay. You happy with doing drug doses, Chris?
Was that, mate?
You happy with doing drug doses next time around?
Yeah, I'm just wondering if it's too soon for them. That's all I'm thinking.
Yeah.
It's only because we haven't got any of the one. I think, like drug dose counts, I think it's up around just before your workshop too.
Before. Oh, okay.
Yeah,
I think everyone was pretty keen to do it. That's all.
Oh, they can do it. Look, I'm happy if you want to do it, but I'm just not sure of how much benefit they're going to get out of it. But at the moment, again, I think leading up to the workshop one, I don't think they do a lot of that sort of stuff.
Got toxicology, shock, acute coronary syndrome.
Did we have one on primary and secondary assessment there, or?
Oh, we did. Yeah.
Yeah. I think if we focused on that to start with, because what happens when they go to the workshop one, that's what they cover. They get taught how to do all their observations and the assessments and all that sort of stuff. And there's set process. Unless you're sort of on top of it before you go in, it's all new. But if we're able to put something like that up, that'll give them a good idea of how to undertake an assessment, secondary assessment, what to look for, things like that. And I think it's just preparation. I mean, if we were getting other students on that were, a vast difference in where they're sitting at, but all these guys are new that are coming on. So I just think it's more of a benefit to them at this point.
Yeah. I'm just trying to have a look at some of the others. APOM cap, triage, burns.
Oh, that's a good one. What was that one?
APOM cap.
Yeah, so that's a good one.
That's PowerPoint.
Yeah, that's a good one. because that's what they'll be doing.
Oh, well, I apologise to everyone. We probably do that one next day. Oh yeah, that's actually a pretty good one too. Yeah, you're right.
Yeah. Yeah, I really think these guys will get far more benefit out of sticking with our moving forward.
Yeah.
I think.
Sorry, everyone. So we'll do drug dose calculations maybe a little further down the track, a little bit later. So that's good thinking, Chris. Thanks. Yeah, it's only APOM cap. It's 17 slides, but by the look of it, it's pretty full. It's a pretty good one. So.
Well, the beauty of that, Col, is we can break it down as we go, so they really know what to look for. Because a lot of the workshop that it revolves around all that stuff, and it's being able to put it all into perspective for you guys, and just take a bit of the heat off, because they go and it's all new, and they're like deer in the headlights, you know, going, oh, geez, what's this all about? I'm not understanding. What's the other one? Sample history, like history taken. You know, ample history and doing all that. All that sort of stuff's important.
Yeah.
The I miss Dambo and sample. The other one I can't think of the name of it.
Yeah, all that sort of stuff is really important. So I think if we do that, it'll stand you guys in good stead.
All right, well, APOM cap it is. And
perfect.
Yeah, I've actually got a few there here on that. So I think I've got a feeling they're both probably about the same, but I'm not sure. But anyway, I'll have a look and we'll do that one. We'll get that out to Sonia to sort out and put it out there for them.
All right.
Yeah. Here we go. Yeah. Yeah. No. That'll be good. That'll be good. Yeah. It's actually good. It's well set out.
Well, that's
right. Clearly, I didn't do it. So.
All good. That's what we want.
All right.
All right, guys.
Happy with that?
We'll see you in 2 weeks.
Okay. Thanks, everyone.
Thanks, guys.
Bye. I'll try to stop this recording now. Somehow. Thanks, Rita. See ya.
Well, what do you think of that, Col?
Oh, that was good. That was pretty good, I thought. I think hopefully we're not bamboozling them with too much.
No, I don't think we are actually.
Some of them seemed a little. Hang on a sec. I'm just trying to. Oh, here we go. Stop recording.